Hi, this is John Kanellopoulos, eye surgeon, medical director here at the Laser Vision Ambulatory Surgery Center in Athens, Greece. And we're going to be talking about our favorite subject, which is keratoconus. We're seeing here a young gentleman who started with advanced keratoconus. Here we can see how the cornea curvature has changed drastically. We reached almost 50 here in keratometry. We performed the Athens protocol, which is a partial in refractive error, topography guided, or in current years, also ray tracing if available, treatment of the cornea irregularity to reach the point today, 3 months later, to have this drastic difference. The difference map on the Pentacams does underline the accuracy of the tracker on the EX500 excimer laser, how in the left eye with the cycle rotation towards the nose, probably about 4 or 5 degrees if I remember well in this particular case, it was able to transfer the treatment right on the spot. So the difference map where the actual laser has flattened the cone and has steepened the flatter area above the cone is as accurate as it can be. We are 3 months out with a -1 contact lens. He reaches 20/20, he's uncorrected 20/30. He began being uncorrected 2100, best corrected 2050. And another key thing that we describe in the post-op management of keratoconus patients that have undergone the AthensProtocol CXL is this map. And this map here is from the OptiView Avanti OCT. It gives us the total cornea pachymetry, which still underlines the thinnest part of the cornea, which the cone was, but also the epithelial map shows how the epithelium is still healing from the hurricane, and excuse me for using this term, of the two procedures, the surface ablation and the cross-linking procedure. We use 6 milliwatts for 15 minutes, that's our sweet spot, and the medication for 2 months with topical corticosteroids. We expect this to turn green, which in colors of this device means thicknesses in the range of 50. When we see blue and dark blue, purple images, we can see the epithelium is still struggling to epithelialize healthy the surface. But the rainbow, if you may, in the horizon here is this cross-linking line, which is deep. It's over 50% depth and it has width of over 7 millimeters. 7 millimeters is the actual diameter of the UV beam with the UVX device. And the cross-section here with the OptiView device is 9 millimeters. So we're seeing also documentation of the depth and the width of the CXL treatment. This is the eye here in slit lamp by microscopy. We have secured a clear cornea, no scarring, a little bit rough surface. Ground glass appearance of the cornea is a sign, early sign of CXL. And again, how we here take pride of treating keratoconic patients and stabilizing ectasia as the #1 parameter. Number 2, normalizing the cornea to the level that this patient will function the rest of his life with an eye that will behave as close as normal as possible. Now, 6 months later, when the epithelium recovers fully, we do have the opportunity to also come in and do a PRK once the prescription stabilizes. We're measuring about -1.5 diopter. We'll see what it is there. We don't expect a big deviation from this, but that's always an option if contact lenses and glasses are not an optimal solution there. But we have to come back and look at the diopter correction. Although we only treated 1.5 diopter with astigmatism and 0.5 diopter myopia from the original refractive error, we can see that the effective correction has 5.4 diopters flattening at this area of the cone when we look at the difference map, and 1.7 diopters steepening at the flatter area. So the total correction here is a little bit over 7 diopters. And despite the 7 dioptric normalization on this irregular cornea, we now that the cornea has normalized, and we can see it has a little bit of regular astigmatism, can measure correctly the refractive error. Again, an example, one of the nicest examples of post-Athens protocol at 3 months. Obviously, the idea would have been, and we've seen this commonly, to have a refractive error of 0. But again, it is impossible to refract a patient at this point. And we discuss this with patients and colleagues alike, because the refractive here is elusive. The patient will find a sweet spot somewhere in this area which gives him or her the best refractive error to function. Once we normalize the cornea, there's really no differential. The cornea becomes a non-multifocal entity anymore. And thus, this is a plateau that can give us the residual myopia that's left beyond the significant flattening that we achieve with the Athens Protocol. Again, this is John Kanellopoulos from our center here at Athens, Greece, signing out. I hope you found this case, this presentation of this young gentleman in his 30 interesting. Thank you very much for your attention.